Hello, everyone. On today's episode, we will be covering communication disorders. Communication disorders are a batch of diagnoses that include language disorders, speech sound disorders, childhood onset fluency disorder, also known as stuttering, and social communication disorder. Now, before we dive into these different communication disorders, it's important to cover a bit of background information on what exactly is the basis of a communication disorder. So, communication disorders include deficits in language, speech, and communication. Those three elements are essentially the foundation of what makes up a communication disorder. And as a result, it is going to be important to define what language, speech, and communication actually mean. So, with language, language is essentially the form, function, and use of symbols to govern communication. It is basically the spoken words, written words, sign language, or pictures that we utilize to try and convey information to another person. Now, speech, on the other hand, is the expressive production of sounds and includes an individual's articulation, fluency, voice, and the quality of their resonance. Lastly, communication includes any verbal or nonverbal behaviors that influence the ideas, attitudes, behaviors, or personhood of another individual. Now, in hearing those three explanations, you may be saying to yourself, these three concepts sound the same, or at the very least are largely related to one another. To one another. And you are correct. However, they hold properties that make them distinct and add relevance to how a communication disorder is conceptualized and diagnosed. For example, I may be able to produce sounds or speech, but not be able to articulate or have the proper motor skills to add form to the sounds in order for them to be converted into language. Additionally, I may be able to chain words together that sound or feel almost like they can be an actual sentence. However, in reality, the quote unquote sentence is barren of any form of communication. Overall, what I'm trying to illustrate is that there are a variety of communication disorders that can be applied to an individual depending on the symptoms that they are expressing. Now, just one more house cleaning item before we begin. When we're trying to formulate an evaluation of a potential communication disorder, we must also complete an assessment of speech, language, and communication abilities while taking into account the individual's cultural and language context. This is most relevant to individuals that may be growing up in bilingual households or bilingual environments. So, for example, let's say you are working with a patient that you suspect may have a communication disorder, or let's say you are working on a research trial focused on a particular language or speech disorder. Regardless of the scenario, you must utilize measures or rating scales that take into consideration verbal and nonverbal capabilities, as well as have those assessments be relevant to the individual's culture and to the linguistic group that they may be a part of. The reason for this is because tests that are developed for one specific group most likely will not provide the appropriate norms for a second group. Now, getting into the meat of the episode, the diagnostic category of communication disorders includes language disorders, speech sound disorders, childhood onset fluency disorder, and social communication disorders. We will first cover language disorders, then speech and sound disorders, then childhood onset fluency disorder, and finally social communication disorder. So, beginning with language disorders, the diagnostic criteria is broken up into criteria A, B, C, and D. Um, Starting off with criterion A, the individual that has a suspected language disorder must have persistent difficulties in the acquisition and the use of language across spoken, written, or sign language. Additionally, these deficits are largely due to difficulties in comprehension or production of language. So, To understand what deficits in comprehension or deficits in the production of language look like, we need to remember these three key factors. Number one, the person has a reduction in their overall word knowledge and vocabulary use. Number two, the person has difficulty in putting sentences together. So, for example, it is challenging for them to put words together to form a complete sentence based on the rules of grammar. And number three, the individual must have impairments in contextual discourse, which essentially means that there is a difficulty in using vocabulary to connect sentences in order to explain a topic, explain a series of events, or just have a conversation with another person. Now, criterion B of language disorder says that language abilities are substantially and quantifiably below what is expected for the individual's age, which results in limitations in effective communication, social participation, academic achievements, occupational performance, or a combination of all of these. Criterion C and D, I'm going to tag together because they have some relation to one another. So for criterion C, it explains that the onset of these symptoms have to have started in the early developmental period of the child, so childhood. And criterion D explains that these difficulties are not better uh, illustrated or just better explained or attributed to some sort of sensory impairment, hearing impairment, motor dysfunction, or another medical or neurological condition. Additionally, these difficulties are not better explained by intellectual developmental disorder or global developmental delay. Overall, the core diagnostic feature of language disorders are difficulties in the acquisition and use of language due to deficits in the comprehension or production of vocabulary, sentence structures, and discourse. The language deficits are evident in spoken communication, written communication, or even in sign language. Language learning and use is dependent on both receptive and expressive skills. In this example, expressive ability refers to the actual production of vocal, gestural, or verbal signs, while receptive ability refers to the process of receiving and comprehending language meaning and messaging. So, to put it another way, expressive ability is the actual production of the language, whether it's verbal or sign language, while receptive ability refers to the individual's capabilities to not only hear the words, but also understand or comprehend the message that the language is trying to explain. I think it's quite important to remember this because language skills need to be assessed in both expressive and receptive modalities, as these may differ in severity based on the individual. To give you another example, an individual's expressive language may be severely impaired, while this person's ability to receive or understand the language is hardly impaired at all. So, one thing we know is that language disorders usually affect vocabulary and grammar, and these effects then limit the capacity for discourse that one might have with a group or an individual. Deficits in comprehension of language are frequently underestimated, as children may be good at using context to infer the meaning of a situation. There may be word finding problems, impoverished word definitions, or poor understanding of synonyms. Problems with remembering new words and senses are manifested by difficulties following instructions or increasing length, difficulties rehearsing a string of verbal information, such as remembering a phone number or a shopping list, and difficulties remembering novel sound sequences, a skill that may be important for learning new words. Difficulties with discourse are shown by a reduced ability to produce adequate information about key events and to be able to narrate a coherent story. When thinking about language disorder, we must remember that the difficulty is manifested by abilities substantially and quantifiably below the expected for age and significantly interfere with the child's academic achievements, occupational performance, effective communication with others, or socialization with others. A diagnosis of language disorder is made based on the synthesis of the individual's history, direct clinical observation in different contexts, such as in the home setting, school, or work setting, and scores from standardized tests of language ability that can be used to guide estimates of severity. Now, when thinking about the development and course of a language disorder, we have to think about and understand that language acquisition is marked by changes from onset in toddlerhood to the adult level of competency that appears during adolescence. Incremental changes appear across dimensions of language, such as changes in sounds, words, grammar, narratives, and conversational skills. Language disorders emerge during the early developmental period. However, there is considerable variation in early vocabulary acquisition, and individual differences are not a single indicator that is predictive of later outcomes. By age 4, individual differences and language ability are more stable, with better measurement accuracy, and are highly predictive of later outcomes. Language disorder, diagnosed from 4 years of age, is likely to be stable over time and typically persists into adulthood, although the particular profile of language strengths and deficits is likely to change over the course of development from childhood to adulthood. There is also great evidence that a positive family history of language disorder can also increase the likelihood that the individual may develop some form of language disorder or have language disorder traits. Now, with language disorders, there are risks and prognostic factors to be aware of. For example, children with receptive language impairments have a poor prognosis than those with predominantly expressive impairments. They are more resistant to treatment, and difficulties with reading comprehension are also frequently seen. As previously mentioned, the language disorders are highly heritable, and an individual whose family history includes a language disorder will have a higher likelihood to develop that said language disorder or some other communication disorder. With communication disorders, there are also differential diagnoses. And really, all indications in the DSM-5 have some sort of differential diagnosis that a clinician has to take into consideration. So, a differential diagnosis is essentially the process a clinician or healthcare provider will take to identify the correct disease or condition from a list of similar diagnoses that share similar symptoms. A clinician will try and identify, or in some instances, rule out the differential diagnosis by comparing competing diagnoses, taking notes of patient and family history, and administering test or clinical rating scales. Essentially, it's understanding the list of potential variations the individual symptoms and diagnosis can take. As a result, with language disorders, there are differential diagnoses that can be seen, such as normal variations in language, hearing or sensory impairments, language regression, or neurological disorders. With normal variations in language, a language disorder needs to be distinguished from normal developmental variations, and this distinction may be difficult to make before 4 years of age. Regional, social, or cultural variations of language, such as dialect, must also be considered when an individual is being assessed for a language impairment. Now, with hearing or sensory impairments as a differential diagnosis, these impairments need to be excluded as the primary cause of language difficulties before an individual receives a language disorder diagnosis. Language deficits may be associated with hearing impairments, other sensory deficits, or a speech motor deficit. When language deficits are in excess of those usually associated with these problems, a diagnosis of language disorder may be made. Now, with intellectual developmental disorder, language delay is often the presenting feature of intellectual disability, and the definitive diagnosis may not be made until the child is able to complete standardized assessments. Separate diagnosis is not given unless the language deficits are clearly in excess of the individual's intellectual limitations. Final differential diagnosis would be potential language regression. For example, loss of speech and language in a child younger than 3 years old may be a sign of autism spectrum disorder or a specific neurological condition. Among children older than 3 years, language loss may be a symptom of seizures, and a diagnostic assessment is necessary to exclude the presence of epilepsy. Typically, to exclude this, a clinician will do a routine sleep electroencephalogram. Now, before we move on to the second communication disorder, which is called speech sound disorder, we need to discuss the relevant comorbidity that exists with language disorders. So, language disorder is strongly associated with other neurodevelopmental disorders. So, for example, some of the more common comorbidities include ADHD, autism spectrum disorder, and developmental coordination disorder. Language disorders are also associated with social communication disorder. And social communication disorder is actually another communication disorder that we will be discussing on today's episode. So just hold on a bit more for that. As we've mentioned previously, a positive family history of speech or language disorders are oftentimes seen in the individual when a clinician completes a family history assessment. Okay, so shifting gears a bit, we'll now proceed to cover the second communication disorder, speech sound disorder. Now, speech sound disorder has four diagnostic criteria, which is criterion A, B, C, and D. Criterion A specifies that with speech sound disorder, typically the individual has persistent difficulties with speech sound production. Production is a key word for this diagnosis. This difficulty interferes with speech intelligibility or prevents verbal communication of messages. Criterion B explains that the disturbance causes limitations in effective communication that interferes with social participation, academic achievements, or occupational performance. And these limitations can be experienced individually by themselves or in combination. Now, similarly to language disorder, criterion C explains that speech sound disorder must have an onset in the early developmental period, so childhood. And criterion D explains that the difficulties are not attributable to congenital or acquired conditions such as cerebral palsy, deafness, hearing loss, traumatic brain injury, or some other medical condition. So, as we come to understand, speech sound production describes the clear articulation of the phonemes that, in combination, make up the spoken words. Speech sound production requires both the knowledge of the speech sounds, of the sound of those words, and also the ability to coordinate the movement of the jaw, tongue, and lips for vocalizing speech. Uh, Therefore, children with speech sound disorder or speech production difficulties may experience challenges with the knowledge, the phonological knowledge of speech sounds, and the ability to coordinate the various movements of the jaw and lips to vocalize speech. It's also important to remember that speech sound disorder is heterogeneous and its underlying mechanism is challenges in articulation. A speech sound disorder is also diagnosed when deficits are not the result of a physical, neurological, structural, or a hearing impairment. And among typically developing children at by age 4, overall their speech should be intelligible. Whereas at age 2 years old, around 50% of the speech, words, sentences that a 2-year-old produces and that you hear will be understandable. The other 50% will be unintelligible. So let's talk a little bit about comorbidity. And funny enough, language disorder, the indication that we just covered previously, may actually be found to co-occur with speech sound disorder. A positive family history of speech or language disorders is often present individual, and of course, this can serve to increase the likelihood that their child or their offspring will develop a communication disorder, whether it's speech sound disorder, language disorder, or the other communication disorders that we will discuss on today's episode. Now, if the ability to coordinate or utilize the articulators, such as the jaw, tongue, and lips, is of serious or severe difficulty, there may be a history of delay in acquiring the skills to use the facial muscles, and thus you may see other difficulties in the individual that aren't necessarily related to speech production or sound production, but are related with chewing, maintaining the mouth closed, and blowing of the nose. You may also hear verbal dyspraxia as a definition for speech production issues. Verbal dyspraxia is a neurological speech disorder where the brain struggles to coordinate the muscle movements of the lips, jaw, and tongue, which is needed for speech, even though those muscles themselves are strong and are not weak. This then, of course, leads to inconsistent speech errors, difficulty sequencing sounds to actual words, and just an overall reduction in the clarity of the word production. Now, verbal dyspraxia allows the individual to understand language. However, there are difficulties with coordinating the muscles of the jaw and the mouth to produce clear sounding words. So, because of that difficulty in articulation, that's why you will sometimes see it be compared or defined as a speech sound disorder or some sort of speech sound production difficulty. Now, what about the development and course of speech sound disorder? Well, articulation of speech sounds follows a developmental pattern which is reflected in the age norms of standardized tests that a child would take. It is not unusual for typically developing children to use developmental processes for shortening words and syllables as they are learning to talk, but their progression and mastering speech sound production should result in mostly intelligible speech by age 3. Children with speech sound disorder continue to use immature phonological simplification past the age when most children can produce words clearly. Most speech sounds should be produced clearly, and most words should be pronounced accurately according to age and community norms by around 7, maybe 8 years old. When when multiple sounds are involved in a word, it may be appropriate or maybe more appropriate to target some of those sounds as part of a plan to improve intelligibility prior to the age at which almost all children can produce them accurately. Lisping is common and may involve frontal or lateral patterns of airstream direction. It may be associated with an abnormal tongue thrust or maybe an abnormal swallowing pattern as opposed to a speech sound disorder. So that's something that a physician should be able to discuss and rule in or rule out based on assessments. Most children with speech sound disorder respond well to treatment, and speech difficulties tend to improve over time. So that's a big positive. And the disorder may not be lifelong as long as proper treatment is put in place. However, when a language disorder is also present, so a language disorder and a speech sound disorder, the speech disorder has, unsurprisingly, a poor prognosis and may be sometimes associated with a specific learning disorder. Unsurprisingly, we have a couple different differential diagnoses that we need to go over for speech sound disorder. So, the differential diagnosis for speech sound disorder include dysarthria, selective mutism, structural deficits, hearing or sensory impairments, and also just normal variations in speech. So let's start with the normal variations. So normal variations in speech should be basically considered because regional, social, or cultural variations of speech need to be discussed before making the diagnosis of a speech sound disorder. So when doing an assessment or just doing a demographic assessment, the clinician really needs to take into consideration the patient's social environment, their cultural variations, etc., before a diagnosis of a speech sound disorder or really any communication disorder is made. The other differential diagnosis to keep in mind is hearing or some other sensory impairment. Now, hearing, deafness, or just some other sensory impairment needs to be considered because hearing impairments or deafness may result in deficits of speech sound production. However, when speech deficits are in excess of those usually associated with these problems, so they are more so of what is expected, that's when a diagnosis of speech sound disorder can be made. Now, with dysarthria as a differential diagnosis, dysarthria is essentially a motor speech disorder caused by nervous system damage, leading to weak or uncoordinated speech muscles, which would result in difficulty in articulating words. It can result in slurred speech, slow speech, or changes in voice volume. With all of these different elements combined, it of course makes it very difficult to understand the speech that a child or just an individual is trying to produce. Dysarthria also affects the muscles controlling the tongue, the lips, the jaws, and the voice box. Considering this, it is important to understand if the individual's symptoms can be better explained through dysarthria before making a speech sound disorder diagnosis. Now, the final differential diagnosis is actually selective mutism. And interestingly enough, selective mutism is actually an anxiety disorder that's characterized by a lack of speech in one or more contexts or settings. Thus, if you have a child or if you have an individual with limited use of speech, you need to also take into consideration or rule in or rule out selective mutism. Selective mutism may develop in children with a speech disorder because of many different factors such as embarrassment about their impairment, but many children with selective mutism exhibit normal speech in safe settings such as at home or with close friends. Therefore, because of the limited use of speech, it's important to clarify if the child's difficulty in speech production is not better explained by selective mutism. Okay, so thus far we've gone over language disorder and we've gone over speech disorder. Next, we are going to cover the diagnostic criteria for childhood onset fluency disorder, also known as stuttering. And then after we finish with childhood onset fluency disorder, we're going to finish off with social communication disorder. We'll then end the episode talking about some of the treatment options that exist for communication disorders and also taking a look at some of the brain physiology in individuals that have communication difficulties. Now, the reason we will save these two categories for the end, the discussion on treatment and just brain anatomy overall, is because most of the information that we will discuss is similar across all communication disorders we've reviewed today. There are some slight differences, of course, but for the most part, once we go through the information, you'll see how just the similarities that they all share with each other. Okay, so starting off with child onset fluency disorder, aka stuttering. This diagnosis is divided into criterias A, B, C, and D. Criterion A explains that in order for someone to have a stuttering disorder, there must be disturbances in the normal fluency and time patterning of speech that are inappropriate for the child's age and, of course, their corresponding language skills. These difficulties, they must also persist over time and are characterized by frequent and marked occurrences of one or more of the following 7 categories. So we'll go in order 1 through 7. So number 1, sound and syllable repetitions. Number 2, sound prolongations of words, so prolonging words. Number 3, broken words. So basically a pause within a word. So For example, saying television, right? So tele, pause, vision, that pause within the word. Number four, audible or silent blocking, which is basically pauses in the sentence or like the whole speech. Number five, substituting words to avoid problematic words. So, kind of changing words up so that you don't have to say that one word that you know you get stuck on. Number six, words produced with excess physical tension. And number seven, probably what's most commonly observed with childhood onset fluency disorder is word repetition. So, for example, instead of someone saying, I see him, they will say, or they will stutter, I see him. Now, somewhat similar to criterion A that we just discussed, criterion B explains that these disturbances cause anxiety about speaking or limitations in effective communication, social participation, academic performance, or occupational performance. And just how we've explained in all of the other communication disorders, criterion C highlights that the onset of symptoms is in the early developmental period. So symptoms must start in childhood. And again, similar to the other communication disorders we've discussed, criterion D explains that the disturbance is not better explained or attributable to a speech motor deficit, sensory deficit, or a neurological insult such as a stroke, a tumor, or a brain injury. So, overall, the essential features of childhood onset fluency disorder is a disturbance in the normal patterning or fluency of speech that is inappropriate for the individual's age. This disturbance is characterized by frequent repetitions or prolongations of sounds or syllables, and by other types of speech disfluencies, including broken words, audible or silent blocking, which is filling a speech or sentence with a pause, substituting words to avoid problematic words, words produced with, again, just excess physical tension, right? So it's just very difficult. You see it in their face. It's very difficult to produce that word. And again, whole word repetitions, which is if you hear someone say, instead of hearing somebody say, I see him, they will say, I see him. Now, the disturbance in fluency interferes with academic or occupational achievement or with social communication with peers or just family members or friends. The extent of the disturbance varies from situation to situation and often is more severe when there is, unsurprisingly, um, pressure to communicate. So, for example, giving a report at school, interviewing for a job, or public speaking. This fluency is often absent during reading, singing, or talking to an inanimate object or pet, which is very interesting in its own right. It is at times also common for childhood onset fluency disorder to be accompanied by motor movements such as twitching, right? So think of eye blinking, tremors of the lips or face, jerking of the head, breathing movements, fist clenching, or tics. It's also important to acknowledge that children with fluency disorder may be seen as having decreased language abilities. However, this relationship is unclear and doesn't really hold up as neatly as some people may think. Um, in other words, children with stuttering or just this fluency disorder show a range of language abilities and can develop a high language fluency and just like a really high and deep understanding of vocabulary. Okay, so shifting gears a bit to talk about the development and course. The development and course of childhood onset fluency disorder occurs by age 6 for 80 to 90% of affected individuals, with onset ranging from 2 to 7 years old. Typically, difficulties in fluency and in word fluency start gradually with repetition of initial consonants, difficulties with the first words of a phrase, or difficulties with long words. As the disorder progresses, the disfluencies become more frequent and interfering, occurring on the most meaningful words or phrases in the sentence or speech, or sometimes even just occurring in more simple words. As the child becomes aware of the speech difficulty, he or she may develop mechanisms for avoiding the disfluencies, such as avoiding public speaking and only using very simple and just very short words to just avoid the stuttering altogether. Now, longitudinal research shows that 65 to 85% of children recover from a childhood fluency disorder. So, that is, of course, a great percentage. Now, the interesting part is that the severity of the childhood onset fluency disorder at age 8 is a strong predictor of recovery or persistence of the disorder into adolescence, adulthood, and beyond. So, what that means is that it seems like age 8 is a critical period in determining how persistent the disorder will be as the individual grows up, or how much recovery can be gained by the individual as they go into adolescence, adulthood, and beyond. So how I read this is that if you have a child that you know has a stuttering disorder, or some sort of or something quite similar. Um, Ages 6, 7, and 8 seem to be very critical periods for introducing them into some sort of treatment protocol, such as speech language therapy. Now, this does not say that if a child is 9 and you or 10 or 11, and that's when you put them in some sort of treatment, it doesn't mean that they won't benefit from the treatment just because they're older than 8. What this is saying is that age 8 seems to be a very critical period. So the earlier that you can start the treatment protocol, overall, the better predictor of recovery of the disorder, into adulthood, into their teenage years, and beyond all of that. So with childhood onset fluency disorder, there is a risk, and there are some prognostic factors to consider. So there is a genetic and physiological risk with stuttering. Research shows that the risk of stuttering among first-degree biological relatives um, uh, of individuals with childhood onset fluency disorder is more than 3 times the risk in the general population. So essentially, if you have a parent or if you have a first-degree relative that has childhood onset, that had childhood onset, or that has stuttering, the risk that the relative or the child, um, the risk that they will develop a stuttering disorder is 3 times higher than the general population. And unsurprisingly, stress and anxiety can also exacerbate the disfluency, and overall just the impairment, cause an impairment in social functioning. And as a result of this, the stuttering may subsequently increase, or in addition to that, the child may develop some sort of uh, anxiety disorder or just anxiety overall. Now, before we move on to social communication disorder, I just want to go over some of the differential diagnoses that clinicians should keep in mind as it relates to stuttering. So, similarly to all the communication disorders we've discussed thus far, um, childhood onset fluency disorder has a variety of differential diagnoses to be aware of. These include Tourette's disorder, adult onset disfluencies, potential medication side effects, again, normal speech disfluencies, and some sort of sensory deficit. So, starting off with Tourette disorder, vocal tics and repetitive vocalizations that are seen in Tourette's should be distinguishable from the repetitive sounds, the stuttering, of childhood onset fluency disorder by their nature and just by the timing of the vocal tics. So, that is to say that the whole word repetitions one might see in stuttering are different in their timing to the vocal tics that you might see in Tourette's disorder. Now, adult onset disfluency as a differential diagnosis is easier to remember because if onset of the word disfluency is is after or during adolescence, it's considered to be an adult onset disfluency rather than a neurodevelopmental disorder that is based in childhood, aka childhood onset fluency disorder. Now, very importantly, adult onset disfluencies are associated with specific neurological insults, such as a stroke or a brain injury, and a variety of medical conditions and mental disorders may be specified with adult onset disfluency. So that's just another batch of factors to consider. Um, Stuttering may also occur as a side effect of medication and may be detected by a clinician or maybe a research clinician completing a robust medical history assessment of the individual. This would include developing a timeline of when the stuttering began and trying to identify if there is a relationship between the stuttering and the exposure of the medication. So basically, did the stuttering occur once the child started taking the medication, just based on the timeline that the clinician kind of developed with the child and just with the parent through questioning, etc. Lastly, sensory deficits need to be considered as potential differential diagnoses. Disfluencies of speech may be associated with a hearing impairment or other sensory deficit, when the speech disfluency is an excess of those usually associated with this problem. That's when a diagnosis of childhood onset fluency disorder can be made. Okay, so the last communication disorder that we will discuss today is social communication disorder. Now, social communication disorder is defined by 4 diagnostic criteria, and of course, those being criteria A through D. Starting off with criteria A, when someone has social communication disorder, there can be persistent difficulties in the social use of verbal and nonverbal communication. Now, these difficulties are manifested through a couple of ways. So, number one, deficits in using communication for social purposes, such as greeting and sharing information in a manner that's, of course, appropriate for the social context. Number two, having an impairment in the ability to change communication styles to match the context or the needs of the listener, which basically means just being unable to change the way that they speak depending on the set and setting or the situation. So, for example, not being able to speak differently in a classroom versus in a playground setting, or not being able to talk differently to a child versus talking to an adult, and just overall avoidance of the use of formal language. Now, number three explains that there are difficulties in following the rules for conversations or narration or just storytelling, such as taking turns in conversation, right? Like just the natural flow of I'm going to speak and then you go and then I go, etc. And not knowing how to use certain verbal signals or nonverbal signals to regulate the interactions or to kind of signal different phases of the conversation or the story that the person is trying to tell. And number four, difficulties understanding what is not explicitly stated and difficulty understanding ambiguous meanings of language. This, for example, can be language or conversations that maybe involve some sort of social or cultural knowledge and understanding, and that can be a little bit ambiguous as to whether this was literal or if it was more sarcasm or if it was more storytelling for the sake of entertainment. And of course, typically when when you're going through the DSM and you kind of get to this diagnosis and this criteria of the diagnosis, people typically think of humor, and stand up comedy, etc., and they would be correct. So humor is part of the ambiguous language that someone with social communication disorder would not really understand as easily as you might expect. Metaphors is another big one, um, or multiple meanings of a word or sentence that, again, depend on the context for interpretation and even just cultural knowledge, even sometimes historical cultural knowledge about things that are happening or things that have happened. So basically, what I'm trying to say and explain with criteria A is that if someone has social communication disorder, you should see some deficits in the person's ability to communicate for social purposes, such as greeting someone, having difficulty in their ability to change their communication style, depending on the situation or the setting that they are in, difficulty taking turns in a conversation, and difficulty again just understanding these words and sentences and just overall language that heavily, heavily is dependent on the context of the situation and just the current environmental knowledge or just cultural knowledge of where that individual lives or what has happened in that area. Now, criterias B, C, and D are a bit simpler and will sound familiar at this point. Criteria B basically says that the deficits result in limitations in being able to communicate effectively, right? In social situations, social participation, in maybe a relationship with mother, father, brother, sister, maybe a significant other, academic achievements, or just deficits in occupational performance if it gets to that point. Criteria C says that the onset of the symptoms must, of course, occur in early development, so childhood. And criteria D explains that the symptoms are not attributable to another medical or neurological condition, or not better explained by autism spectrum disorder, intellectual disability, global developmental delay, or another mental disorder. So, overall, social communication disorder is characterized by primary difficulty with pragmatics or the social use of language and communication as manifested by deficits in understanding and following social rules of verbal and nonverbal communication, changing language according to the needs of the listener or situation. So again, difficulty or a deficit in being able to do that, and following rules for conversations and storytelling. So I want to spend maybe 2 minutes going over comorbidity associated with social communication disorder. And the reason is comorbidity with social communication disorder is a bit tricky to pin down because the very essence of the diagnostic criteria of a social comm disorder fits very neatly in a wide variety of indications. Some of the more common comorbid diagnoses that one sees with this disorder includes ADHD and specific learning disorders. When I first learned about social communication disorder, my mind immediately went to social anxiety disorder as a potential comorbidity. However, it's important to remember that although the symptoms of social communication disorder overlap, there is great difference between these two diagnoses. Social anxiety disorder is an indication we will cover in a future episode. But to give you a quick preview, this diagnosis is defined by intense, persistent fear of social situations where the individual might be humiliated or scrutinized by others. This fear leads to significant distress and avoidance that disrupts daily life, work, or relationships. So, you might be thinking, okay, well, social anxiety disorder is defined by avoidance of social situations due to fear of humiliation. So there must be some connection between this anxiety disorder and communicating in social situations or communication disorder. However, it's important to remember that although the basis of social anxiety disorder stems from intense fear of negative judgment, social communication disorder involves difficulty in using language socially. So again, this means understanding social cues, taking turn in conversations, greeting someone, understanding the switch in conversation depending on the set and setting, and understanding ambiguous language such as humor or metaphor. And this is all occurring despite normal language development. So, social communication disorder is not necessarily just rooted in fear, but there seems to be some neurological differences in the individual. So I'm going to try and simplify this a little bit more. Social anxiety disorder's core is fear of scrutiny, which leads to physiological anxiety symptoms such as sweating and trembling, while social communication disorder focuses on an impairment in language skills, impacting the flow of conversations and social understanding. This is despite having normal language development, and these deficits could occur regardless if the individual has or feels anxious in that moment. Um, People with social communication disorder want to connect but lack the tools to do so. So I know this was a bit lengthy of an explanation, but I just wanted to take some time out to explain that and also kind of give a preview of social anxiety disorder. We'll talk about social anxiety disorder again, actually, when we get to the differential diagnosis and, of course, in a future video. So, this is just some food for thought, essentially, as we work our way down to the differential diagnosis category. Okay, so moving on to the development and course of social communication disorder. Because social communication depends on adequate developmental progress in speech and language, diagnosis of social communication disorder is rare among children younger than 4 years of age. By age 4 or 5, most children should possess adequate speech and language abilities, um, enough to a point that would permit the identification of a specific deficit in social communication. So basically, by age 4 or 5, a parent or a caregiver um, would be able to more or less tell if there is some deficit in the child's social communication capabilities. Now, milder forms of the disorder may not become apparent until early adolescence, which is kind of when more complex language and more complex social interactions begin. The outcome of social communication disorder is also a bit variable, with some children improving substantially over time and others continuing to have difficulties persisting even into adulthood. Even among those who have significant improvements, the early deficits in pragmatics that are involved with social communication disorder may cause lasting impairments in a child, adolescent, or adult's ability to develop social relationships and behaviors, and also deficits in acquisition of other related skills such as writing ability. What about the risks and prognostic factors related to social communication disorder? Well, when thinking about the risks of social communication disorder, it is well known that genetics and physiology play a part in the development of this indication. For example, a family history of autism spectrum disorder, communication disorders, or specific learning disorders appear to increase the risk of a child developing social communication disorder. Now, that actually leads me perfectly into the next section, which is differential diagnoses that one should consider for social communication disorder. So, as a clinician, when thinking about differential diagnoses, one of the first disorders you will need to assess for is autism spectrum disorder. Autism spectrum disorder, again, we'll have an episode on this, but ASD, autism spectrum disorder, is the primary diagnostic consideration for individuals presenting with social communication deficits. The two disorders can be differentiated by the presence of restrictive, repetitive patterns of behaviors, interests, or activities that's commonly seen in autism spectrum disorder. This is because in social communication disorder, the restrictive repetitive behavior and interests and activities, etc., is not observed. So that's really the highlighting feature that separates these two diagnoses from one another. Individuals with autism spectrum disorder may only display the restricted repetitive patterns of behaviors, interests, and activities during the early developmental period. So, a comprehensive history should be obtained from the person. Current absence of symptoms should not preclude a diagnosis of autism spectrum disorder if the restricted interests and repetitive behaviors were present in the past. A diagnosis of social communication disorder should be considered only if the past developmental history fails to reveal any evidence of restrictive, repetitive patterns of behaviors, interests, or activities. So basically, what this is saying is that, or what the last few sentences are saying, is that once you do that comprehensive timeline, history of the individual, if there's no real showing of restrictive or repetitive behaviors, that's when you should consider a social communication disorder. Now, the second disorder clinicians need to think about when thinking about a differential diagnosis is ADHD. Primary deficits of ADHD may cause impairments in social communication and functional limitations of and for effective communication, social participation, or academic achievements. So it's important to understand if the deficits are due to the wide array of symptoms shown in ADHD, hyperactive type, or inattentive type, or if the deficits are strictly due to the difficulty in the social communication. So again, ADHD is another big indication that we will cover in a separate episode. Now, we talked about this next one already, this next disorder, but the third diagnosis, or the third differential diagnosis a clinician should consider, is social phobia or social anxiety disorder. Now, symptoms of social communication disorder do overlap with those of social anxiety disorder. However, the differentiating feature is the timing of the onset of symptoms. In social communication disorder, the individual has never had effective social communication. In social anxiety disorder, these social communication skills develop normally, but they're not utilized because of anxiety, fear, or distress about the social interaction. So that anxiety, that fear, and just that avoidance really is one of the bigger differentiators between both of these diagnoses. So again, in social anxiety disorder, the individual they can communicate socially normally. They do have those skills, but because of that intense fear, it prevents them to be able to do just that. While in social communication disorder, regardless of if the individual is in a safe environment or if they're in an anxious environment, although if they're feeling anxious and fearful, the social communication disorder is probably even more severe. But what I'm trying to say is that even if they're in a pretty safe, pretty neutral environment, those difficulties in social communication disorder will still be present. So I'm not going to spend too much time on social anxiety disorder because we already kind of discussed it a little bit. And again, we'll have an entire episode focused on social anxiety disorder. So we'll put a pin on that and we will come back to it at a later episode. Okay, so that was a overview description of all of the major communication disorders in the DSM-5. Now, the next thing that I want to discuss is the different brain circuitry that's involved in each of these communication disorders. So this would mean, or this could mean, underactivation or overactivation of a particular circuit or pathway or just brain region, or maybe some sort of brain insult, stroke, or tumor on one of these sections of the brain that cause a lot of the difficulties with a communication disorder. So we'll start off with defining the different core brain areas of language disorder. And through those definitions, we'll be able to see why some sort of insult or just underactivation of these different brain areas would cause deficits in communication and language overall. So the first brain area to cover is Broca's area. Now, Broca's area is concerned with production of speech, grammar, syntax, and planning out what you're going to say, or expressive language planning. So, as you may be able to put together, a deficit in this area, or some sort of insult in Broca's area, is going to produce a lot of difficulties with actually producing speech. Now, Wernicke's area is concerned with language comprehension of spoken words, so being able to understand the language that you're hearing and being able to retrieve the right speech and the right speech sounds, the phonemes, based on what you're hearing. Wernicke's area is also involved in comprehending and producing speech and also just semantic processing. So, as you can imagine, damage to Wernicke's area is going to heavily impact the individual's ability to understand the language, to process the language that they're hearing. The middle and inferior temporal gyri is also involved in word meaning, similar to Wernicke's area, and it's also involved in storage of semantics and language processing. Now, the angular gyrus is located in the posterior parietal lobe, and one of the main functions is concerned with semantic processing as well as connecting the visual recognition of a word. So, seeing a word in a book, for example, recognizing and connecting that recognition with the meaning and the sound of the word. So, you recognize the word, and then in your brain, you connect the how that word looks, like the recognition of the word, with the meaning of that word and the sound. So if I'm reading a book and I see the word bird, my the angular gyrus is gonna recognize that word. It's then gonna connect the recognition of that word with the meaning. So a flying animal, and also I might think of some sounds that a particular pigeon or just a particular bird will make. And that entire process is going to contribute to our ability to comprehend reading and writing, but also to create a story in our head through imagination based on what we're reading. Now, the last core brain area for language disorder that I want to cover is the arcuate the arcuate fasciculus is a white matter tract that connects Broca's area in the frontal lobe and Wernicke's area in the temporal lobe. As you could probably imagine, damage to this area is going to cause a lot of difficulties in communication, specifically for word production and word comprehension. Okay, so next we will cover the core brain areas that are involved in speech sound disorder. So these core areas really focus on speech motor planning and motor execution. So we'll start off with the left inferior frontal gyrus, which is involved in phonological planning, supports sentence formulation, and also word retrieval. Now, really the main core brain area of speech sound disorder is going to be the premotor cortex, the primary motor cortex, and the supplementary motor area. Now, the core brain areas associated with childhood onset fluency disorder is going to include, again, Broca's area, premotor cortex, and the supplementary motor area. So we just covered that, but just very quickly, Broca's area, of course, concerned with production of speech, while the premotor cortex and the supplementary motor area is all about initiating and the timing of speech, and of course, speech motor sequencing. So organizing speech sounds and just converting different linguistic plans into actual motor plans. The other brain area that is associated with stuttering is the cerebellum. Now, the cerebellum is involved with timing, rhythm, smoothness, balance, and coordination of various faculties, which of course includes speech. So the cerebellum is going to be involved in the precision and the error correction process of speech production. Now, the next brain area is called the basal ganglia, and the basal ganglia is made up of the caudate nucleus, the putamen, the globus pallidus, and the striatum. And this network focuses on controlling voluntary movements, so movements you want to do, by selecting them and initiating them, while suppressing unwanted ones. So, selecting and initiating desired actions, and then suppressing unwanted actions, depending on the setting or the individual that you may be with. And so, as it relates to speech, the basal ganglia is going to help start speech at the right moment and regulate the speech rhythm and pacing. And as you could probably tell, this has a lot of implications towards stuttering. So, if there's some sort of challenge with the basal ganglia, that capability that the basal ganglia has to start speech at the right moment and regulate speech rhythms and pacing, there's going to be some deficit, right? Because with stuttering, you're going to have those whole word repetitions. Such, I think the example that we gave is "I see him," and then someone that has childhood onset fluency disorder or stuttering is going to say something along the lines of I see him." So the basal ganglia is going to be involved in that speech rhythm and that speech pacing. So if there's some sort of insult to the basal ganglia, you're going to have a lot of difficulties with the rhythm of the words that you're expressing and the pacing of those words as well. Okay, so now the last set of brain areas I want to cover are going to be related to social communication disorder. So, social communication disorder and the brain areas involved are going to have a lot to do with social cognition and, of course, the language network. So, we're going to be talking about a lot of the prefrontal cortex, the amygdala, and also the orbitofrontal cortex. So, with the medial prefrontal cortex, this is the brain area that focuses on understanding others' intentions, beliefs, emotions, and overall perspective taking in social situations. The medial prefrontal cortex also works to interpret social norms and context. So, as you can tell, many of these are key factors that are sometimes missing in an individual that has social communication disorder. Because, of course, part of communicating socially is being able to understand other people's emotions, understanding their perspective, and also understanding the social situation that you're in. So, if someone has social comm disorder, there's going to be a deficit there. And so, that's why one of the brain areas that we first look at with social communication disorder is the medial prefrontal cortex, because we want to see if there has been some insult to it or if there's just some limited activation in that area. The next brain area to discuss is the amygdala. So the amygdala focuses on detection of emotionally salient stimuli with a special focus on fear and threatening emotions. The amygdala also helps in assigning valence to the emotion to help determine if it will be a positive emotion or a negative emotion, depending on the interpretation of the social situation. The amygdala plays a role in communication through its ability to assign emotional salience to these social situations. So, for example, being able to interpret emotional tone of speech or modulate speech output based on the emotional context. So, as an added example to kind of relate it to social communication disorder, as we mentioned earlier, one of the features of social communication disorder is um, not understanding that there are differences in communication depending on the setting that you're in. So, if you're at a playground setting or if you are in a classroom setting, and with those settings, there's going to be different emotional tones, right? When you're in a playground, the emotional tone might be much higher, much more excited. Where when you're in a classroom, it's going to be much more dim, much more slow. And so that feature that the amygdala has in being able to interpret emotional tone of speech based on the social context, or modulate the level of speech output based on the social context, is going to be diminished in someone with a social communication disorder. Now, the next brain area that I want to cover before we move on to treatments of communication disorders is the orbitofrontal cortex. So, the orbitofrontal cortex is going to focus on assigning value to an outcome depending on if it was a loss or a gain. It's going to regulate impulsivity. It's going to inhibit inappropriate responses. It's going to evaluate and process appropriateness of one's behavior and the social rules of the situation. So the orbitofrontal cortex is going to play a role in communication by filtering what should or should not be said, especially in a social situation, regulating the appropriateness of a conversation or situation, and helping suppress socially offensive speech. So, for someone that has a social communication disorder, all those essential features of the orbital frontal cortex may be diminished, and so that diminish would only serve to exacerbate more of the symptoms that we observe in someone that has social communication disorder. Now, it should be noted and understood that brain physiology is not the only etiological feature that should be considered when trying to understand a communication disorder. Communication disorders are highly complex and involve various other factors from the culture the individual is a part of, the individual's upbringing, and the quality of their home, school, or social environment. The purpose of discussing brain physiology as it relates to communication disorder is more so to learn about how the different areas of the brain function and how some of these areas relate to communication or difficulties in communication. That's why you may have heard me, as I was going through these core brain areas, discuss what the overall function of that particular area is, and then how it relates to communication or how it may relate to a difficulty in communication. So, overall, it just should not be used as the singular feature to determine a diagnosis, nor should someone with a communication disorder immediately believe or jump to the conclusion that they have a diagnosis or that they have this particular communication disorder diagnosis because of some insult or lack of activity in any of the brain areas that I explained. These psychological disorders and processes are highly complex and require a biopsychosocial view in almost every instance. Okay, so what about treatments with communication disorders? Well, the general treatment principle across all communication disorders is going to be speech language therapy as the primary standardized therapy. Some diagnoses, like speech sound disorder, may require articulation therapy to teach the individual the motor movements required for the specific sounds and words. However, this is typically baked into the speech language therapy manual, or it can be added as additional sessions if it's not included in the speech language therapy manual. Now, one thing I should also mention is in therapy, and especially with a lot of these diagnoses. So, let's take, for example, speech sound disorder. If someone comes in for treatment for speech sound disorder, the primary focus may be the articulation therapy. However, that does not mean that the person won't need assistance or some sort of practice in strengthening their vocabulary or understanding the rate of words and sounds or just learning the social rules of communications. In many cases, for a lot of these, if not all of these communication disorders, yes, the individual is going to come in for the primary symptoms that they're experiencing based on their main diagnosis. However, this does not mean that that's the only thing that they're coming in for or the only thing that they're experiencing. In many cases, individuals also want to strengthen their social communication or strengthen their vocabulary, and through speech language therapy, they're able to achieve that. Now, early intervention, not surprisingly, is going to be key with speech language therapy, as it is the strongest predictor of a potentially positive outcome. Typically, with speech language therapy, the treatment is individualized and developmentally appropriate depending on the child's age, maturation, and capabilities. It's common for caregiver and parent training to also be provided during speech therapy so that the initiatives that are learned during the therapy session can continue to be practiced at home. School-based supports are also common and critical in determining a better prognosis. And there may also be, of course, real-world based practices or group practices. And really, overall, it's important that those real-world practices and those group practices are completed in various settings, such as home setting, school setting, or in the playground, so that the child can robustly develop their communication capabilities across various situations. Now, some of the modalities speech language therapy focuses on are vocabulary enhancement, sentence formulation, narrative formulation, motor-based training for specific sounds, stuttering modification techniques, social understanding and inference, strengthening conversation skills, turn taking, staying on topic, understanding sarcasm, and understanding non literal language. Because communication is needed for all aspects of a person's daily living, it is not uncommon for comorbidities such as anxiety, ADHD, or learning disorders to develop as a result of the disruption or interference a communication disorder can cause. Because of this, speech language therapy may at times be combined with cognitive behavioral therapy to target the various experiences the individual may be working through. This can include targeting avoidance behaviors, negative self concepts, anxiety, task completion, task understanding, and motivation. Overall, the key takeaway is that communication disorders have well regarded treatments that have a thorough structure and targeted approach based on the individual's needs that build functional communication skills over time. Okay, so that wraps up today's episode on communication disorder. Thank you again for taking the time out to listen to this episode. If you're learning from these episodes, please consider subscribing or clicking the follow button. That simple, zero cost support is incredibly motivating and truly appreciated.